Greetings to everybody. We are having our 44th intergenerational meeting. Our guest is Mariana Pinto de Costa, and Rojda Ersönmez will moderate the meeting. I'm leaving the floor for Rojda now.
Hello, everyone. Thanks for joining. Today, our intergenerational meeting is about digital psychiatry, and Mariana Pinto da Costa will be our lecturer, let's say. She's a senior lecturer at the Institute of Psychiatry, Psychology and Neuroscience, King's College London, and a consultant psychiatrist at South London. She has a lot of things in her CV, but I will let her introduce herself.
Thank you very much for the kind introduction, and thank you very much, Bulent, for the invite. As I was mentioning previously, I know that we're just in the middle of August, so I know that people are very cheerful and excited with the summer, but I'm very pleased that you chose to be here today. And I want to also salute Professor Norman Sartorius, who I've seen who joined as well. The meeting. Today I'm going to discuss some topics about digital psychiatry, so I think it will be great to have your views and to have, I guess this topic really sparks an intergenerational discussion. So I hope we have that discussion in the end as well. I have some slides that I prepared. I'm going to try to see if I can share my screen. Let's see. Can you see my screen?
Yes.
Yeah? Okay. Shall I start, Rojda?
Yeah, please go.
Okay. Well, so good morning, everyone, and thank you very much for inviting me to contribute to this session. So I'll be giving an overview of different considerations about digital psychiatry, and I will make some provocative questions that I hope spark some discussion in the end. So we talk about digital psychiatry, but we already live in a digital society, and there are more phones than there are people. There are billions of emails that are sent every day and thousands of social media posts per second, which really illustrates how technology is everywhere beyond healthcare. So digital mental health has the potential to revolutionize mental health care. And in recent years, there has been an explosion of interest in and research on the use of technology in mental health. And the focus ranges from the prediction of future illnesses, early detection of illnesses, assessment of illness level, and improving access to treatment. And I will give an overview of how technology has been used, as well as its potential future pathways for clinical practice as well for research. And this ranges from the use of telehealth, electronic health records, electronic prescription, smartphone apps and sensors, robots, virtual reality, and also, and very, very topical, artificial intelligence. So we will try to cover all of that in today's talk. So starting with telehealth, which is a bit sort of like the basics of digital psychiatry. And telehealth involves essentially the use of telecommunication to deliver healthcare outside of traditional healthcare facilities. So it's a bit like what we're doing today in this talk, that we're using Zoom and remote platforms to communicate with people in different places and help to bring people together. So this is seen usually as the most basic element of e-health. And it can use a wide range of information and communication technologies. So it could cover text messages, video messages, but also audio calls. And this is very much used in healthcare. For example, in the UK, the NHS, so the National Health Services, offers this service that you can see here in the picture, which is called GP at hand, so General Practitioner at Hand. And this provides access to a GP 24/7, so 24 hours, 7 days a week. Other countries have similar initiatives of online therapy. And in the United States of America, there is an app called Talkspace, which allows people to have access to a licensed therapist online by writing asynchronous messages. And their package of unlimited messaging therapy comes with a slogan that emotions can't be scheduled. And it offers people the opportunity to message a personal therapist with whom they are matched with whenever they want. And it has already thousands of therapists registered from across the country. But of course, this raises questions about also the therapist relationship, because usually there's a setting and a context and a time and a space that a professional speaks with a patient. But in this format, and specifically this format that is being advertised here, shared here, you can see that the idea is this idea of continuity in which you could have potentially continuous access to someone, which really shifts what is the context of therapist encounter, but may actually also pose questions about dependency and autonomy and so forth. Another important use of technology are the electronic health records. And in the future, this will possibly lead us to have real-time patient health data, which the care teams have access to, with dashboards that link primary, secondary, and social care data to produce really an integrated care for patients. Yet when we move towards these complex data collection systems in a health information ecosystem, this poses questions about the different users that can have access to the data and would be able to modify it. So would the electronic records be retrieved by all health, social, and even perhaps justice authorities, as well as patients? What about if there are disagreements about the content of the joint history data? What would be the mechanisms that would or would not allow for modifications? Or even a more provocative question, will all these data in the future be somehow more publicly available anyway, which could mean that the concept of privacy and confidentiality in healthcare as we know it today maybe will disappear. So these are, of course, some food for thought and for question for us to think about. Now, another valuable use of technology is the prescription without paper, where the medication prescribed can be collected in the pharmacy directly. And this cross-border e-prescription is working already in several EU countries. And patients are able to go to a doctor in another country, and their healthcare data from their home country can be consulted by the doctor overseas. And you can see here a list of the services that are available in different countries like Czech Republic, Malta, Portugal, Croatia, Spain, Luxembourg, and Estonia. So this is an example of an initiative that was done in this case in the European Union. However, the EU member states have different data protection and confidentiality laws, which might have perceived as barriers to such initiatives. But the fact that I think this is rolling already in different countries shows that even when there are barriers, if there is really political will, it is possible to do such things in a regulated way, which I think is also an important point for us to discuss. Is sometimes, of course, there are different barriers, but if there's will and if there is political will, there can be mechanisms in place to address and mitigate risks so that you actually allow technology to be implemented. Another use of technology are sensors, and these potentially can be a bit more controversial, which essentially are devices whose purpose is to detect events. That's sort of like the definition of a sensor. In the United States of America, the Food and Drug Administration has approved the first sensor pill, which is the Abilify Mycite, is an antipsychotic aripiprazole. And how it works is that the oral tablet is embedded within an ingestible sensor that allows patients, and if given access, doctors and caregivers to track the medication ingested on a smartphone or a computer. So essentially, the system sends a message from the pill's sensor to a wearable patch on the patient, which then transmits to the device. So the example of this sensor sort of like changes the notion that we have about adherence to treatment, because the whole concept of adherence to treatment has very much been based in self-report information. But now with the use of technology, we can actually know, or we have the tools and the resources to allow ourselves to know if people or patients have actually ingested a medication or not. Smartphone apps, there is an ever increasing number of smartphone apps for different purposes, and mental health is no exception. In the United Kingdom, we have the NHS Apps Library, which aims to help patients and the public to find health and well-being apps that meet the standards of NHS Digital. But an article published in Nature Digital Medicine on the evaluation of mental health apps is asked whether we are using science to sell apps. And they found that of the 73 apps they evaluated, they noted that there was only some lived experience involvement in 14%. There was only in 19% some information about wisdom of the crown. So, for example, like testimonials for users or endorsement from the press. And there was only in 32% some sort of credibility of the development team, like a professional endorsement or even prizes or awards that apps would have gained. So there was, I guess, like little information about the quality and the perceived quality of the apps. And quite importantly, none of these apps referenced sort of like a quality development or assessment, as in official accreditation or app certification. So in the stage, John Torres and his team, they proposed the APA app evaluation model. And the four main areas covered, besides gathering basic background information, are safety and privacy, evidence, ease of use, interoperability. However, since apps are constantly updating and changing, this could mean that these evaluations can be quickly out of date. And also determining the usability can be very subjective and depends on how each patient experiences and it feels after using it. So maybe I appreciate using an app and I enjoy it, but maybe Professor Bull and Koskon or Professor Norman Sartorius don't enjoy it so much. So there's some element of subjectivity in the personal experience of using an app, which might make it difficult then to create fixed standards or fixed rates. Robots have also an increasing role in mental health, and they have mostly been used to help treat children with autism or older adults with dementia. Robots, as you can see here, they can vary in appearance from very mechanical looking to very anthropomorphic. And humanoid robots have been criticized capabilities, with some arguing to be unethical to use when treating vulnerable populations. So in this first picture, we have the EU-funded Mario project, which was developed to be a companion to reduce loneliness and isolation in people with dementia. On the other hand, many people have a latent fear of non-humanoid robots, perhaps due to science fiction movies in the 60s, like the Daleks in Doctor Who. While for pets, the pet robot Paro, which is a seal, has been used in care homes as a substitute for physical animal therapy, reducing loneliness. And interestingly, some pilot research even found a decrease in blood pressure when the participants had these Paro robots, and then an increase of the blood pressure when the robot was withdrawn. So this shows that actually the patients that were using Paro had an impact in the decrease of their blood pressure levels, which I think is also a future avenue for research as well. But of course, all this leads to several questions. For example, Google has obtained a patent on robot personalities. So what will happen if the robot is programmed to take on the personality of real-world people, like a celebrity or a deceased person? Would this be a door to have humanoids living forever and in several places? Also, with service skills and personalities in place, robots could replace many customer service, taking over many human staff positions once robots are cheaper and more efficient than humans. And another controversial example is the citizenship that Saudi Arabia gave to the social humanoid robot, Sofian. And by having citizenship, would she be able to vote or get married? So these are a lot of ethical and provocative questions that we can discuss and consider. Virtual reality is increasingly entered our lives because the headsets, they can be used with our own phones and they are increasingly cheaper. In mental health, virtual reality allows to recreate the scenarios in which the psychological difficulties occur. For example, exposing the person to the environment, triggering the cravings associating with their alcohol abuse and smoking. VR has also been used in domestic violence offenders, making them experience a virtual scene of abuse themselves through immersive virtual reality in a female virtual body. So essentially, they saw a virtual man who displayed violent behavior towards them. So if they were speaking, they would be shouted, "Shut up." And if they were looking elsewhere, they would be shouted, "Look at me." And this research that was conducted in Barcelona has showed that changing the offender's perspective improved their ability to recognize fear, improving their empathy. So this is quite interesting how virtual reality can be used in scenarios that has positive outcomes, including helping people to improve their empathy skills. Also, research done with veterans with post-traumatic stress disorder in the States even tested as well a virtual therapist. And interestingly, in this research, it showed that veterans were more likely to reveal information to virtual coaches than to face-to-face therapists. I guess virtual coaches can respond predictably and efficaciously. They never fatigue and are not subject to transference and counter-transference reactions that can compromise communication. And equally, I'm aware that this specific study was done with veterans, so there might be specific contexts with veterans that might have made these results that the veterans had were more likely to reveal information to virtual coaches than maybe face-to-face therapists that they knew or were having some hierarchical role within the system. Artificial intelligence, which is the hot topic now, it has also a lot of potential in mental health care, but the field of artificial intelligence is not new at all. As you can see here in this picture, what you can't see is an increasing awareness of it. And this figure shows the increasing number of Google searches on the Google platform about artificial intelligence and machine learning throughout time. So sometimes there are some confusion about the terms of what is artificial intelligence, what is machine learning, and what is deep learning. So I included this figure here to help clarify the definitions. So essentially, artificial intelligence is sort of like the overarching term and is the human intelligence that can be exhibited by machines. Now, machine learning is essentially an approach to achieve artificial intelligence. So it is a technique that enables the machines to learn the tasks with the experience. And deep learning are the algorithms. So the actual algorithms that permit the software to train itself to perform the task. So these are the different definitions that are very much used nowadays, although sometimes they are used interchangeably, but they mean different things. And a lot of estimates have been done about the potential of AI, especially in healthcare, either enabling more precision and efficiency with significant cost savings, with surgeries assisted by robots, using virtual nursing assistants that can monitor patient systems and behaviors, diminishing visits to patients, but also with the integration of artificial intelligence in admin work. For example, a number of hospitals and services now are testing the scribes using AI. So essentially, you are having a meeting, either a multidisciplinary team meeting or with a patient, and the AI records everything. But instead of transcribing verbatim, as in word by word, as it was done in the past, this AI technology now makes summaries and then helps with the documentation that, depending on what is said, then it can provide like a template summary that then can be used and added in the electronic health record. So this is being piloted and tested and implemented now. And there's also been a lot of estimates looking at the potential of artificial intelligence on reducing dosage errors and improving as well the detection of fraud. Now, in this work on predictions, there were different predictions done, and I think predictions are always interesting. First, it would be that artificial intelligence would help us to enable different developments across time. First, improving how we perceive the world, then developing cognition, then helping us to build relationships, which is just about the time frame that we're entering. And then it was estimated that by 2036, AI would be filling our own roles. And there has already been some research. For example, there was a randomized controlled trial that was published earlier this year, and they tested using generative artificial intelligence, so like ChatGPT, in patients with common mental disorders, and compared with humans. And they actually found positive outcomes, although now there has been a lot of criticism on the potential risk of bias of that randomized control trial. So there's more and more research that has been used and being conducted to test the efficacy of these interventions. Now, in terms of perceiving the world and monitoring behavior, there are t-shirts that monitor our heart rate, our breathing and movement, as also fitness tracking devices. There are also biosensing tattoos whose colors change when your blood sugar levels change, which can help for people, for example, with diabetes. There's research being done with cars to detect alcohol levels and instruct people to stop if the driver is drunk. And this is being tested by two different mechanisms. One, sniffing a driver's breath, and the other one, scanning the blood in the fingertips through the steering wheel. So you're, driving your car and you have like your fingers in the steering wheel. And then it's being tested whether you can, see the alcohol levels, and if you're fit to drive, and if you're not, then the car has the potential to stop. But of course, all these devices may pose concerns, and sometimes there's also data that becomes available that was unintended. So, for example, some years ago, this fitness tracking app called Strava gave away the location of secret American army bases through the geolocation data, pinpointing overseas facilities. So all these American people from the army, they were like running and using the fitness tracking app, but suddenly, like in the Middle East, they were seeing lots of people running there, and then of course it was pinpointing that there was like an army base there. So of course sometimes there are unintended consequences of using such technology. Moving on to speech, which can be collected passively and can be quite rich. Another example is Sound Health, which created an app to elicit and collect speech samples along with questionnaires. And data were collected from a general population sample in the United States, where participants completed several voice tasks on their personal smartphones on uncontrolled natural environments. And as you can see here in this graph, the depressed speakers have difficulty in producing more energetic, aroused, or happier, more positive valent speech than the non-depressed speakers. Also, if you look at the content of the words, they use words and phrases that take less effort and have less articulatory precision. So there's a lot of work and a lot of research done in mental health on speech analysis, but actually in other areas. So the other day I read that there was research happening at the moment that can actually, through speech, detect if someone has diabetes, which I'm not so familiar with the exact mechanisms, but I find fascinating how we can now, through speech, know if someone has diabetes. I think these are all avenues that technology has really the potential to help to detect conditions much earlier on. Facial analysis is also promising in this multimodal framework to help with diagnosis and monitoring. And looking at facial and head motion can help us explore, for example, the smile duration and intensity. So, of course, if someone is a lot of time not smiling or smiles for a very short period, and we can also compare different people throughout the time. So you can also like monitor recover throughout time thanks to facial analysis. And another example is body movement. So there's also been research using body movement scales. And you can see here in this figure that show that lower Amityville rating scale scores were linked with higher movement activity. So that's other avenue and potential of using technology. So I guess essentially overall using technology in the clinical and research setting involves really, as you can see, a large number of important things to consider. But quite important as well are patient preferences. So in my research, I've been looking at whether patients prefer face-to-face or digital interactions when speaking with a volunteer in the community. And we found that younger patients were more interested in technology as compared to older patients. And those with lower quality of life were more interested in having face-to-face contacts. Also, the expectations of these interactions varied. For example, those who were more keen in face-to-face contacts, they wanted to do more activities. But those interested in digital contacts, they wanted to make a new friend. So they wanted someone to talk with and, you know, someone to have an informal chat and some another person to be in contact with. And these findings have helped to develop an intervention that we tested in the feasibility trial, where patients with psychosis were matched with one volunteer in the community with whom they could speak over the smartphone through audio calls, video calls, messages, and emails. And we offered participants a smartphone and monitored their communication and step count. And as you can see, we were in this intervention feasibility trial, we were actually looking at the communication that was exchanged between the two participants. But we also had, and for that, we used Sketch Engine, which is a software that allows to analyze the written communication. And this is an online text analysis tool that works with large samples of language like SMS and emails. And you can see the most written words included things like good, hope, well, family, working, safe, God, sorry, thanks, and busy. And we also conducted end of study interviews. And this intervention was quite positive to some of the patients, and as this quote illustrates, saying that the phone call that the patient received on Christmas is something that he will never forget. But also for volunteers, so that people who are volunteering to support patients, they expressed a positive impact for their personal and professional lives. And in some cases, even speaking when they were in different countries, overcoming long distances, like we are having now. We're having like a meeting and different people from different parts of the world are together. So I think it's great that we have technology to really bring people together. And we're actually now doing this larger test of this intervention through a randomized controlled trial in different parts of the country in the United Kingdom, because this feasibility trial, everything happened in London, and London is an urban area, and we're now investigating how this works not only in urban areas but also in rural parts of the country. It has been said that AI will allow doctors to be more human, but I guess we can extend it and reflect whether technology is allowing humans to become more humane, as in if technology helps us to do some tasks that might be a bit more burdensome, then it might help us to bring back positive values and be more humane, that sometimes might be principles that are not used every day. Interestingly, going back to this discussion about predictions, it has been predicted that by 2045, all advances in technology will outsmart all human beings in the planet. And this possibility might give rise to the increase of transhumans, which raises many questions. For example, would it be ethical to allow surgeons to replace someone's limbs just to outperform and run faster? All these matters are important to discuss. Who is accountable, why, and under which values? How autonomous will we be in the future, and what is the chain of decision making? How much privacy will there be? How much transparency will there be? What will be influencing our choices and our decisions? Maybe in the future, our cars will decide for us. I mean, you have this cartoon of these cards saying, no, I will not take you to McDonald's. I will take you to the gym. So maybe, you know, our cars will stop us to go to unhealthy places. However, it is important that the humans ensure that the purpose of the machine is in line with what we really want, so that the cars that just don't start doing random decisions that are against our main human values. So a number of research priorities for digital mental health were previously identified, and they were published in the Lancet Psychiatry as a policy paper, and I'm sharing these questions here. So if you're interested in digital mental health, but you haven't quite identified what research question excites you the most, I hope this paper, but also this talk, gives you some inspiration and food for thought and reflection. So thank you very much for your attention, and I hope that we can discuss some of these points now, and I would be very, very, very interested to hear what you think about some of these issues. Thank you.
I want to sincerely thank our speaker, for this inspiring discussion, first of all. This discussion has shown me that digital psychiatry is a far broader and more complex field than I had realized before, definitely. So if there are any thoughts or reflections on this topic you would like to share with us. we would be happy to hear them. I'm telling this to our participants. Yeah.
Yeah.
Professor Norman Sartorius, please.
I want to congratulate you, Mariana. I think this is the most competent description of the whole field I've heard so far. It's wonderfully done. It's clear. My suggestion to you would be on the basis of this that you produce it as a whatever you call it, a YouTube or something else. I think that people can, or a booklet that would give people information about what is contained in this field. It would be a wonderful thing to read. I'm sorry that my wife didn't listen to it because she'd be interested to hear it. But I'm saying this not because she's my wife, but because she's of a different profession. And I think it would be just as important that we inform others. I think it's almost done, your presentation, to be ready for wide distribution. And I think it should be handled as such. So congratulations. It's really been excellent. And I hope that you will spend a little more time. I'll be happy to give you advice if you want it about things that might be slightly improved about the information, but there is very little of that more formal than anything. Now, having said that, I think it's also important that we retain as a main line of argument that all of these things are to serve humans. They are not a replacement of humans in any way. They are tools which we can use to make our function in relation to patients or in relation to other people more effective and easier. So as long as the technology remains our servant, we are doing fine and we'll do better and better. If you allow it any time that it becomes our master, we'll perish and it will be a terrible world. So congratulations again. I think that you should publish this or put it available and make it a widely available document that people could learn what it is all about. Thank you very much.
Thank you very much, Professor Norman Sartorius. I appreciate your support. And I know that there's always sparkling discussions about the importance of human connection, which I think we both agree. But I guess sometimes it is true that some things might be missed with technology. But at the same time, I think we're in a digital society, and I try to give an overview, and I'm glad that that it worked. So I hope that later on we have an opportunity to discuss further. Professor Sartorius wanted to add something.
I have one little comment. Everything is fine except for the title. Because it is in fact, it should be a title should be the use of digital technology in psychiatry rather than digital psychiatry. I think that it is in fact the wonderful field of what you described, which should serve you as a psychiatrist or any other psychiatrist to do their work better. Any doctor to do their work better. In fact, almost anybody who is in public service to do their work better. It's not digital psychiatry, it's the help of the digital world to performance of psychiatry.
Thank you very much, Professor.
Well, I have a question about what Professor Norman just said. Basically, not replacing humans with robots, but how we are gonna force the companies to do that? Because now we know, like in United States, I'm gonna give an example. Like most senators get paid from PACs, and those PACs are basically companies, and those senators basically protect the companies. So how are we gonna force companies not basically replacing humans' work for cheaper robots' work? How are we gonna force that?
Yeah, I mean, I think when I hear different examples like yours and others, I think it prompts me to think what is essential about human beings and human interaction. And I say that from society level, but also from the perspective of the health professionals and the medics. Because if we focus specifically on AI is being used in different areas within healthcare, including in psychiatry, as this trial that I was mentioning, that was the first RCT to investigate, generative AI, which essentially it's like what we would usually call ChatGPT, but of course ChatGPT is like a commercial, so they use a different one that is not like commercial, that had principles to behave as a therapist, and they compare that against the therapist, and they had like favorable outcomes, and it was the first trial. It makes me think, what is then essential about being human? And I think principles like compassion, empathy, and kindness, which I know that engineers are also trying to develop. But I think they're still very much at the core of what we are as human beings. And I think we should all very much reflect what is then unique about ourselves that machines don't do and they won't do. And so, for example, even this trial that I was mentioning that was published this year, it had a lot of human oversight. And they found that on some occasions there were glitches of either the AI giving inappropriate advice or not always working as intended as the algorithm that has been created. I mean, it's true that sometimes humans can also have issues, but these are not like glitches as such, right? So I think we really need to concentrate what is essential about being human, and that we develop tools and technology that fills our what is it that helps us to be more humane, which I personally think, in terms of my opinion, and I think there's a lot of performance tasks that technology can help quite a lot, and maybe they don't require the human soul to do it, and they can help to alleviate the burden of the human, allowing us to then be more humane, if that makes sense. That's one point. The second point about knowing who pays and who doesn't pay, I think goes back to my previous reflection, which is privacy and confidentiality. And on one hand, I think some institutions are trying to move away from privacy and confidentiality. But on the other hand, I think society as a whole is moving to becoming more transparent in lots of fields. Like, for example, like science, you have the entire movement of open science, and everything like is publicly available, and of course pseudo anonymized, but you have entire databases of studies like publicly available and so forth. So I think that is happening within society and in different fields, including, and it should include other areas. Can you hear me? I'm not sure if my internet is working very well now.
Yes, we hear you.
Okay. Any other thoughts or reflections?
I have one question, if possible. Okay, so first of all, congrats and thank you for such an inspiring talk. I would like to ask if you have information about acceptance by patients of the mentioned sensors, and that is linked with the fact of we live in a society where patients increasingly demand their autonomy, their individuality, and I don't know if this monitoring might bother them.
Yeah, no, thank you very much, Bernardo. I mean, I personally am not connected with a company that developed the Abilify, sensor, so I don't have like specific data. But what I explained was the way that they developed. Actually, they developed the sensor in the research trial, so that it gives the information to the patient. of course, that's what they developed for ethical reasons and to provide autonomy and empowerment to the patients. But of course, these developments raise questions about how it would be if it is used in a different way. So instead of giving the information back to the patient, how it would be if the information was given to a third person. But personally, I don't have these details, but maybe once we meet someone from that company, we can discuss and know whether they are going to share their data on what they've developed and the extent of what is being used and by whom. Yeah, do you have another comment?
Hello, I have asked question and comment.
Yeah, sure, go ahead, Bart.
Before the pandemic, online therapy sessions weren't available, and it was said they weren't available for a therapeutic relationship. However, many people uh, are now using online therapeutic sessions, but some professionals say they might not be mm, the same as for face-to-face therapeutic sessions. What are your thoughts on this? Maybe you have mentioned, but I haven't heard. I have missed, maybe. Did you say anything about this?
Yeah, I mean, I personally think that there are differences between having online sessions versus face-to-face sessions. And you're absolutely right that during the COVID-19 pandemic, it really, from a position of need, it really accelerated the implementation of telehealth and teleconsultations. I actually have a PhD student who is doing like a PhD. She's investigating the differences between face-to-face and remote consultations in different diagnoses in mental health care through different studies. And what she found so far was that in a number of conditions, the results were the same, except when patients were more severe. And there were also some metrics that for either patients that had other conditions like dual diagnoses or like severe mental illness and substance use disorder, that the online consultations weren't so good. Whereas in what she found was in situations like minor depression or anxiety or personality disorders, that remote consultations worked well. So that's what the research that she did, that she looked at all the literature that was published in the field across the world, since forever, and then did sort of like an umbrella review looking at the outcomes of the different studies that were done with different types of patients, and then did a meta-analysis to synthesize. And I think my opinion is very much like in line with what she found in the research, which I think it's a platform or doing consultations face to face or remotely might work for some, but not for all. There's the element of the patient's preference. There's also the element of the therapist's preference. And in some circumstances, like severity, like if someone is extremely unwell, then the likelihood that the remote consultation is going to work is lower. And obviously, when you are having an online consultation, you're seeing the person in a screen that primarily allows you to see the face. And if the person, moves a lot, maybe the hands, right? But there's all the other parts of the entire body that you're not seeing. And so there's a lot of non-verbal communication and non-verbal presentation that, even if we're very much pro technology, just gets missed in remote consultations because of the screen format. So that's like something that really like plays a difference. But at the same time, of course, if you want to have an appointment with a therapist and there's like a huge waiting list and you would be waiting for, I don't know, 2 years, or if you live very far away from a hospital or a care center, or very far away for someone who could provide you support, and you have this alternative or this possibility of having an appointment that is via technology that makes your appointment more rapid, which I think is very much driving why remote consultations are still very popular, even if we're not anymore in the COVID-19 pandemic. I think that's also very good because we know that in general, early detection and early support is good. So you don't want to be a lot of time or too much time on a waiting list, waiting for a face-to-face consultation, when maybe you can have a remote consultation faster or quicker. So I think on the balance, I think there's the patient preference, the therapist preference, the access to technology, and the quality of the technology. So I'm actually doing research with some other colleagues. This is still being investigated, but we're looking about whether the access to the internet and the quality of the internet has an impact in mental health outcomes. And what we have found so far in our preliminary results is that actually the quality of the internet also has impact on the mental health outcomes, which I'm sure some of you may resonate, because maybe when you are in a place and it has internet, but the internet is not very good, then you get, I don't know, like upset or it's possible to imagine why these findings seem to be like this. So I think it's like a complex field, but at the same time, what I do think from from a training perspective is that medical students and residents and trainees need to be trained how to deliver consultations face to face, but they also need to be trained how to deliver consultations remotely. And the way how you do both as a therapist is different, because the way you interact with a patient in a remote consultation is different. So, for example, little things like where you look at. If you look at your screen, which would be where the face of the person appears, which is what you do when you are with a person, in the same room, then for the other person, it appears that you're looking a bit lower and not to their eyes and to their face. So for the person who is in the other side, for them to seem that you're looking to their eyes, you actually need to look to your camera, which usually is a bit further, on top of the screen. So you need to look at your camera and you're not seeing the person. And then the person in the other side will see that you're looking at them. So all these things that are slightly nuanced, they require training. And I think we should acknowledge that they are different. And I think we should train both medical students as well as residents and doctors on how to deliver both. I hope that responds to your question, Bartu.
Thank you.
Well, I have another question about remote counseling. Do you think remote counseling would affect doctors in the high earning areas like United Kingdom, United States? Because like the same effect of remote call centers might affect remote counseling as well. Like doctors in lower wealth areas like India, Pakistan, Africa, like South Africa, South America might consultate patients from United States, United Kingdom, and other basically medical experts on the richer areas might get jobless. Do you think this effect is gonna play a role in remote counseling?
Good question. First of all, I think we more and more live in a globalized world. And so I think when concerns the internet, I think it's less country A and country B, but on some aspects is actually Dr. A that is registered as a doctor in country A. And I'll give an example. So in the UK, it was some weeks ago launched the NHS 10-year plan. And in the UK, in some areas, there's a lack of doctors. And one of the things that the NHS new 10-year plan is saying is that they support that remote consultations are delivered, including from medical doctors who are outside the UK but are registered in the UK General Medical Council registry. And this is something that is being recommended by, this massive policy document that is very high level and dictates how healthcare should happen in the UK. And this has a lot of implications. So, for example, what they are saying now is, imagine like a doctor who is registered in the UK General Medical Council, which of course has a lot of oversee and checks all the safeguardings and all of that. But if this medic is registered in the UK registry, but they are, I don't know, living in Switzerland because, the country is so nice and it has mountains and great hot chocolates, and chocolate and all of that, they are saying that they should be allowed to provide remote consultations to patients in the UK. And this is to address the problem that is the shortage of doctors. And if it's a problem in the UK, it's also a problem in several other countries. So there's also this point on how you can use technology to access care. And I think the problem of shortage of doctors is not a problem that is limited to some low and middle income countries, because some high income countries like the UK, you might have a lot of doctors in cities like London, but equally in other rural areas, maybe very few people want to be there. And so even if it's a high income country like, the United Kingdom, in some rural areas, there are not doctors there because people don't want to go there. So this allows people that are in other places and they see patients that are based in these rural areas that some people don't want to go. But now in this policy document, it was launched like a few weeks ago, really, like the higher level said, we should allow people that are outside the UK, as long as they are registered in, the General Medical Council, to see patients in the UK. I mean, I'm sure you all are based in different countries and you will be familiar with your own policies and rules. And of course, this is always linked with governments and how governments see things. But this is something that just happened now. And I think it's interesting to reflect the potential implications. And of course, this example is extremely fresh.
May I?
Yes, please, Professor.
First of all, thank you very much, Mariana. Really, I'm very much impressed. And in a way, my mind was full of questions while you were presenting. But the main question I want to ask you is, with the new role of yourself as the chair of section on education in World Psychiatric Association, what can you suggest or focus maybe on how to develop these issues in medical and residential education? Maybe you may need to have a group out of the section on education from other organizations as well.
Yeah, no, thank you so much, Professor Bulent-Koskinen, and thank you so much for all your support throughout the years. I'm very pleased that we had elections in the section on education, and I was recently elected as chair of the section of education. And with the elected board, we had a board meeting recently, and we are going to have a new composition of the board in which different elements different colleagues, they're going to be focusing on different areas. So we're going to have like a research lead, a policy lead, members engagement lead, and so forth, because I really want to try to have the board very much involved, and people are also very excited to contribute. And I hope with this new structure within the section that everyone has a specific area that they are the lead, that then we can create task forces with members and with people from other sections and from people from other organizations, so that we cover as much areas as possible. Because as we were discussing in our recent board meeting of the section of education, there's always the element of education. So one of the colleagues, they were also part of the schizophrenia section, and they were saying, well, it's so important, education about schizophrenia. So everything in psychiatry, one way or another, everything has an element of education. So we really want to cover in different areas. And one of the areas that I personally am very interested and committed is around technology, and how we can use technology also to have new methodologies to teach. And I know the younger generations, I think I'm at this stage, I think I am career, and the younger generations, even how they teach and they learn, has much more gaming elements and gamified elements. And one of our colleagues that was elected for the board of the section of education, Sami Juanes, he has created with another colleague, Lamia, like the WPA quiz, which is a format of education that is very interactive as well, and it uses technology. So we hope to have like a strong team and bring everyone who is interested to contribute to education in psychiatry, to cover all these areas, including technology. So watch this space, and I will be sharing a lot of opportunities, and I hope to work with you all.
Excuse me, may I add one more thing? And can you also try to activate the participants of our seed, which, as you know, is full of silent members. This is an issue which might draw their attention. Maybe you could also motivate some young colleagues in seed.
Yeah, no, absolutely. Happy to.
Thank you.
So do you have any more like questions or feedback before concluding our section? So if nobody has, then we thank our speaker once again for this inspiring discussion. And yeah, now we are concluding our section, and thank you for joining us, everybody.
Thank you very much, Rajda, for sharing, and thank you very much, Bulent, for the invitation. I hope you have a lovely day.
Thank you.